We do have two other experts, Dr. Shweta Bukhanali. I hope I haven't made a mess of your surname. If you could
Yeah.
turn on your
Yes,
video,
Dr.
please.
It's Dr. Shweta Buchanali.
Okay, thank you for
Yes.
that, and I apologize. So she's an IBM certified data scientist, a doctor of pharmacy graduate, and she's done pioneering research in the field of liver tumor histology, utilizing state-of-the-art deep learning models, which I fail to be able to pronounce. So I'm going to skip that. Actually, for the first time ever in one of these AI webinars, we have somebody from the industry to give us insights from the other side. And our other panelist is Dr. Sonal Asthana. Everybody knows him. He's a hepatobiliary transplant surgeon from Bangalore, vast experience in the field for over 2 decades, worked across Europe, North America, and India. He's a well-published academic, a scientist, I must say, faculty position at the Indian Institute of Science, where he's working on various projects. And of course, most important, which I feel he made an impact on, is that he's the past president of the Liver Transplant Society of India and has been a key cog in sort of transforming the society into a very academic one. Welcome, Dr. Sonu. We'll start off with
Thank
the first question, which is actually something which is there in the chat window asked by Dr. Suchet Chaudhary from Medanta. My question was actually to the three of you. Is there any difference between the East and the West with regards to how you would want AI to be incorporated into our system? And that's what Dr. Suchet is also asking, because he's asking from a liver transplant perspective, wherein in the West it is all DDLT, while in the East it is LDLT. So my question, if you can take it by turns, Dr. Mamatha first, and then Dr. Sonal and Dr. Shweta, is there a difference how we approach AI and healthcare between the East and the West?
Yeah, so thank you for that question. I think that when we develop AI algorithms, we have to take into consideration, the unique aspects of practice in each country. So what works in one country may not work in another country, depending on different environmental factors in general. So say if I develop an algorithm in Toronto, it may not validate externally in, say, at Rela Institute in India. Now, so that's just a general answer. I think the reason for that is going to be, say, different clinical considerations, environmental considerations. The population is likely to be quite different. So, but I think that the advantage of working very closely with computer science experts is that you can understand why it is that, say, an AI algorithm is not working in a different environment, and actually identify those factors and try to modify the model to actually work in that context. Now, the other potential is to then instead develop a new model. Say, if we're talking about DDLT versus LDLT, I think we have to just develop a new model, train a new model based on, say, the LDLT population. So if we're looking at the LDLT clinical question specifically, which is what Dr. Chaudhary has brought up, if you want to understand the optimal donor-recipient matching, then you can only train that AI algorithm on patients who have received a living donor liver transplant. And that is only feasible by, say, training on these data sets from the Eastern world. So whether it's, say, South Korea, Japan, where LDLT are the dominant forms of liver transplantation, as well as in India. So I would say, all of our projects need to be informed by the local clinical context and really inspired by the questions that we are encountering, the problems that we are encountering on a day-to-day basis. And that's what I would encourage everyone to do, because I think that there are unique issues in the Indian medical context that are very important to understand. And you have, say, the advantage of generating a large amount of data uh, that can then be used to train algorithms, test algorithms, and then also offer lessons to the broader community. So I think there's a lot that can be learned. Say a tool that works well in India may work well in a different country within Asia. And there's a lot of lessons that can be learned, I think, through such collaborative projects within India.
Sure. Dr. Sonal,
I
and what's
want
your
a
view
general
for
answer.
changing?
I hope that addresses the question. I mean, I, what I'm saying is, I think all of us as clinicians have to be inspired by the day-to-day questions that, or day-to-day problems that we encounter, and how can we use AI to address those issues.
But my only issue with that would be to ask you, do we need to start from scratch in every region? Can we not sort of just tweak what's existing
Correct.
in another region and then sort of, build on what's already there?
Correct. So you can do that as well. I mean, it depends on the clinical question, I think.
Yeah, sure. Dr. Sonal?
I mean, thank you, Dr. Mamatha. Excellent presentation as always, and also to Dr. Ashwin for inviting me. I think both those questions are very relevant. Dr. Mamatha has given a really good sort of idea on how to approach it. Firstly, so part of it was actually I to draw you back to her own presentation about how you can enhance the sensitivity or the prediction of a model by incorporating certain parameters as pre-filled parameters. Like for example, if for example a clinician finds that say gamma GT elevation is elevated or associated with say biliary problems rather than rejection, for example, in the Indian context, then if you could, you could incorporate that as pre-existing knowledge or prior knowledge, and so there could certainly be some tweaks that could be made in a model that already exists to make it more relevant to ourselves, giving our clinical context. And those tweaks are necessary because the patient population we see, the spread of disease is significantly different between geographies, such as the United States or North America and ourselves. So that is one thing. That certainly, when it comes to perhaps a prediction model where a lot of variables are already similar, and we probably have to, adapt the model to our own clinical sort of inferences, then we could probably make tweaks, as you just said. But when it comes to changing something like, for example, donor-recipient matching and living donors, I mean that's completely different because the donor risk index that we know is completely based on deceased donation. And a lot of the things that we talk about donor marginality, ethnicity, cold ischemia time, those things are not at all relevant in the living donor context, right? On the other hand, technical complexity, which is quite important and probably underrated in living donor, the number of bile ducts, the number of portal veins, the number of venous reconstruction that you need to do are probably underrepresented in any model that we have at this time. So I think that when it comes to that degree of change between DDLT and LDLT, which is quite significant, we do need to have our own prediction model. The best thing we can do for that is currently the ILTR, which is the largest data set we have to date. Every institute such as the Rela Institute or Vedanta do have their own data sets, but the LDL, the biggest experience in India currently is in the ILTR. So we have about 7,000 patients there, and Dr. Bhat and I are looking at a project together to see whether we can do something similar in India, which perhaps comes up with a calculator which gives us an index of risk. One of the other things that sort of came to mind just now after Dr. Bhatt mentioned South Korea was that we do have an MOU with South Korea as well now, between the LTSI and the Korean Liver Transplant Society. So we could certainly increase this as perhaps a project that would perhaps be the largest of its kind in the world, because they're definitely better at collecting data than we are.
Perfect. Dr. Shweta, a view from a techie's perspective with regards to how AI is different in the East and the West, and how you're going to be able to deploy it, or at least teach us doctors to work on it. You're muted. Dr. Shweta, I'm not sure. She's not able to log in. Dr. Sonal, I just wanted to ask, further to what you just said in the last few sort of sentences of what you were just saying. And is there anything of an Indian sort of endeavor in this regard with regards to AI
Uh,
and machine learning?
well, I mean, there are numerous endeavors which are sort of micro endeavors at this point. For example, I mean, I'm like there's an initiative at the Relay Institute itself to use AI in
Yeah,
digital pathology, and that's being tried by various centers separately. Um, what I would probably say is that there is no integrated endeavor as of now, and that's probably what we need, because we do need a baseline which would help us. You're not just the larger centers that already have a lot of collective wisdom, in their kitty, but even new centers that are starting out to have some idea of risk and prognostication when it comes to variables that are unique or specific to our condition. So, Dr. Bhat and I are have put a proposal together for ILTR data analysis, which is currently ongoing, and we hope to do that. And like I said, perhaps even using data sets from other countries which have got a transplantation split similar to ours is something that should be considered.
sure, perfect.
Yeah.
Dr. Shweta, you back on?
Yes, Dr. Ashwin.
Yeah, perfect. I'll just repeat my question in case it was lost in the connection.
Yes.
Basically, I wanted to know from a techie's perspective as to how easy or how difficult it is to deploy these AI tools, in India versus say in the West, and how different AI is itself here versus there.
So when we are trying to build AI models, data set becomes very important, right? And the data which we collect and train the model on is different in different geographical locations. Like when we take patients from different countries, that considers different factors. Whereas when we are using that model in India, the factors change, right? So it is like we have to produce a model which can either be generalized to the whole of the geographic locations, or we can develop a model which is specific to our geographical location, right?
Mhm.
Because different factors are being considered over here. Generalizing these AI models become very important in this case. And building a model in India nowadays might not be that difficult, because of the recent technological advancements which are taking place over here. Now we have moved to electronic health records, the imaging advancement has improved a lot. So now there is a diverse data set available. So building a new model and considering the factors which Indian population are facing would be far better these days. So that is how we can build an AI model which is specific for our geographical location in this particular situation. Yeah.
Mhm.
Yes.
That's a fair point, actually.
Mm.
That actually takes me to my next point. I mean, as doctors, we are quite resistant to change. So I would like
Yes, Dr.
your input, both Dr. Shweta and Dr. Bhat and Sonal. How easy is it to actually convince a doctor to switch and ask him or her to actually move into the AI world? Dr. Bhatt, from your experience in Canada, do you think it's an easy endeavor?
I think that in general, whenever you're introducing new technology to, physicians, there can be, resistance, there can be neutrality, and there can be enthusiasm. And those groups will be, say, in a one-third split, I think, based on my experience. And this is what I've heard from other colleagues who have been trying to, say, deploy tools into the healthcare setting. So I think this is natural human behavior. I think ultimately you have to convince physicians that the tool is giving safe and reliable predictions, and that this will be used as a co pilot, not as the pilot in their patient's care, and that they can, you know, uh, I think one important aspect is to have Shapley analysis, so interpretability of the algorithm, because that gives the physician trust. It gives the patient trust in the prediction. So, say, for example, if you have diabetes as the top risk factor predicting cardiovascular outcomes or cardiovascular events in a patient, for example, or other, say, factors that, say, clinicians identify as being important contributors, that will give more trust. So, the other thing is actually, physicians may be resistant to change because they don't want something increasing their work burden. So all of us are already, overburdened with clinical care, administrative paperwork, this, that, and everything. So we want to, say, reduce burden, not increase burden. So if you offer an AI tool and in the end it's going to increase clinical alerts and then really just adversely affect even a physician's quality of life, they'll be less likely to accept it. So I think that this is just human nature anywhere you are. That there are going to be people who are very enthusiastic and then others who will be less enthusiastic. And you have to convince the less enthusiastic bunch that the AI tool that you're deploying, first of all, is trustworthy and reliable and also will not increase their work burden. And ultimately, also, administrators have to be convinced that you will be helping them decrease healthcare costs, not increase healthcare costs. So I think there are, like various aspects of this whole issue. Um, but I would say in my experience, and this is going to be the same in India, I'm sure. Maybe in India, depending on the setting you're practicing in. So, say the private healthcare setting versus a government setting, there are different considerations. And so, you want to have solutions that will help them help physicians in their care of patients, make it more streamlined, uh, and improve outcomes and efficiency, right? So if you can convince people of that, then they'll be more likely to adopt a solution.
Sure, sure. That's a fair point. Shweta, Dr. Shweta, what has your experience been as somebody who's had to speak to doctors to try and
Yes.
convince them?
Yes, Dr. Ashwin. Yeah, so I want to reiterate, very nicely put, Dr. Mamta. So you have covered all the a lot of points. So my personal interaction with doctors have been that in India, especially, is have been that firstly they are very much with patients. They are
I think your
work,
voice is glitching.
workload, right? And second, use tech in their every. Is it Dr. Ashwin?
Yeah, no, I said your voice is glitching. You could maybe turn the video off and continue speaking. Yeah,
Okay. Is it better now, Dr. Ashwin?
yeah, of course.
Yeah. I'm sorry for the issue. Yeah. So my personal experience with doctors in India was that they're burdened with work, burdened with a lot of patients, and using tech with every patient. Putting all the data into the tech or in the application becomes difficult. But that said, if they see the advantages of it, that comes after using it for some time, when they see the advantage in, predictions, in getting the trust on the application, then there might be a change, and that is a slow process, but it will get up after initial phase, is what I think. Yeah.
Dr. Sonal, mm, what do you think?
Yeah, I think that one thing that I'd like to add to what the panelists have said is that I often find that it's a design problem. So yeah, I'll explain what I mean by that. Technology barriers in India, of course, it's not to say that, I mean, we have technophiles and technophobes everywhere, and that will be a challenge. But in general, the amount of time available per patient in India is a little lesser, and most EHRs, most mechanisms of collecting data aren't designed to do that in an effective manner.
Hmm.
To sort of give you an example specifically for India, most EHR that we have are actually billing software. Billing software that have been repurposed in some fashion to collect some clinical data. So when I look at our own EHR in the hospital, I will get data on ICD for every patient. I will get data on the medicines used, but the mechanism of collecting clinical data is a little bit broken. So, and equally, when you look at collecting fragmented data, like we have patients coming with reports from multiple different hospitals and labs, etc. We don't really have a good mechanism of collecting that data. So I think that a lot of mechanisms of data collection need to improve, design to make it usable. So which is like voice to text is very underused in India, for example. This is something that, I mean, it's not just true for India; it's true for the US, the
Hmm.
UK, and Canada as well.
Hmm.
Some of my wife's colleagues are considering retiring after the new software has changed because they don't find it usable at all. And in Edmonton, in Canada, so there is a fairly I think that certainly resistance to change is part of it, but a lot of these problems are actually design problems. So that really means that people who design software for data collection should actually sit with clinicians and figure out what the workflow is and solve for pain points. Okay. The second thing is also people need to know that it's reliable because doctors are conservative for a reason. We know that what has been working for our patient. I'd be extremely reluctant to change something that's been working well for my patient
Hmm.
for something that is unknown. Okay.
Yes.
So that kind of confidence building can only come with data. That can come with dialogue such as the one we're having now, and
Yes.
also making sure that we're talking about the data that is clinically relevant to doctors in a particular geography, right?
Hmm.
If we were sort of, if this entire meeting was say about hepatitis B, then perhaps all of us would not be that interested, because we probably don't see as much. Our patient population would be a little bit different. So I think that those are two probably specific examples that I'd like to also add to this discussion.
Can I just add to that? Actually, I would say, Dr. Ramohan. So if you just think about technology, like say the technology that you use at your center, the robotic hepatectomy technology, that again, as Dr. Asthana mentioned, many surgeons would be reluctant to use that if they feel like things have been going very well already. So they are achieving excellent outcomes. Especially more senior surgeons are unlikely to change their practice because they don't see the value. And so then it's up to centers who have started, say, the early adopters of the technology, to then demonstrate that the outcomes of introducing such innovations or such new technologies is actually better than the standard of care. And so, similarly, if we can demonstrate this, like say with the AI tools that we deploy, not just developing the tools, but actually deploying and showing that there is improvement in patient outcomes, decreased healthcare costs, et cetera, and quality of life is improved in our patients, then you're more likely to convince more and more physicians to adopt the technology. And then the other thing is also having patients as advocates. So in the Western world, I think there's been a lot of, say, collaboration between patient advocates and physicians to, say, improve funding for a given clinical question or clinical research program, because, say, patients feel strongly that this is something important in the longer term to improving their own health. So I think I don't know if such a similar context exists in India. Depending on the center, I'm not familiar enough. But if you have people who are, say, advocating for introduction of AI tools into the healthcare system because they see the value of this. So not just physicians, but also having patient advocates for this. I think you will see that kind of change. And it also involves, say, general population education as to what could be the benefits as opposed to the risks.
Ashwin, I'd like to add something to this because just as design, if you sort of look at Dr. Bhatt's slides about how sort of the personalized information was given, it was actually very nicely designed because it was non-intrusive. It sort of showed the benefit that could accrue from making, say, a specific change. So it was very visual. It was easy for somebody to understand, and so I think that that kind of design would be very non-threatening. Equally, when you look at, say, something like Cure.ai, which is, I should have mentioned that, which is India's largest initiative for chest radiographs and which is quite commonly used now across Southeast Asia. The way they kind of annotate the chest X-rays is very non-threatening, as in it will be, the X-ray will come up and it'll have marked certain points, and essentially it would be like a resident asking a doctor, hey, I've marked out these points, and you think that this is okay or not? So I think that design solves the problem also perhaps of the insecurity of, hey, is this machine telling me what to do, and is it sort of overriding my years of experience? I think that that's those are questions that can probably be addressed well, or those are concerns that will be addressed well with well designed UX UI as well as tools. So
Yeah, and I think the other thing is, AI tools will learn on the amount of data or the data sets that you feed it. So, say a junior physician will have a certain number of experience, but the AI tool will have trained on multiple physicians generated data, so on thousands of patients. As long as
yeah,
you're feeding this data to that algorithm. So I think,
yeah.
if you feed more and more data to an algorithm that is unbiased and clean, there is an opportunity to actually help, especially more junior people, people in the community, say community physicians, family physicians, general practitioners, and actually democratize the knowledge that, say, subspecialists have to help
Mm.
outcomes on a larger scale.
Oh, oh, that's a fair point, actually. Both of you have sort of encapsulated what I sort of had an idea with regards to introduction. Obviously, you need to have awareness of what AI entails and what it is likely to do,
Mhm.
and then importantly, there needs to be a trust in the system itself. And as doctors, especially as surgeons, and I'm sure Dr. Sonal will agree that we are very egoistical people, so we don't want our egos to be touched when AI is being introduced. So obviously, yeah, I think all these three components would sort of help it, smoothly sort of ingratiate itself into our practice.
Yeah,
But
two other points.
Yeah,
Sorry, I
go.
should add. The this offers us the opportunity to be more objective, also, in our decision making. So as long as, again, the AI tool has been trained on a good data set and has been prospectively evaluated, there's this opportunity to make things in medicine more objective and not so subject to individual physician preferences or experience. Maybe you, as a surgeon, you encountered a certain issue maybe like 2 months ago, and that is actually like having I don't know, like an overwhelming, impact on the way you practice medicine or practice surgery. Having an AI tool in the background would offer a certain objectivity and kind of over remove that overwhelming influence on the decisions that, say, one surgeon makes or one physician makes versus another. That's one thing I wanted to say. The other thing is, coming back to the design issue, that Dr. Asthana mentioned, we do have a human healthcare factors team that works along with us to ultimately design solutions that would be easy for clinicians to use. So we do perform surveys of the clinicians who would be using this tool to ensure that the dashboards are designed in such a way that they would not disrupt the flow of their workflow. So similarly, this is what people have on, the type of expertise people will have on their team, which is, say, cognitive, psychologists, like behavioral psychologists, actually, like people who can understand what are things that would be helpful versus not as helpful. How should we design the dashboard in such a way that it is, promoting the workflow as opposed to disrupting the workflow?
And I mean, Ashwin, just sort of this one, I was having some discussion with some game designers about a week or 10 days ago, very interestingly. And I strongly believe now that game designers are better than behavioral psychologists when it comes to understanding how to keep people engaged and hooked and, and move forward with the game. So the way they design and certainly the parameters that they take, I think that again it brings back Dr. Bhatt's point about having more diverse people on the team. Because that these are not things that come intuitively to a surgeon or to a clinician actually. So I think that people coming in with these diverse viewpoints can only add to the quality of output that we produce.
Absolutely. Yeah.
Yeah. This actually sort of triggered another thought in my mind. So we are now speaking about cold objective data being fed in, and then that sort of spewing out, what are the likely outcomes, what are the likely prognosis and things like that. But at the end of the day, as doctors, we always have that emotional component. There
Yes.
needs to be empathy, sympathy, all of those bits and pieces which play an important role. Do
Yes.
you think, I mean, I would like Dr. Shweta's input as well. Do you think AI can at some point incorporate those aspects into just cold data?
Potentially. I think, when we see patients in the clinic, so I'll tell you, during COVID, it was interesting, right? So we had, say, virtual care, sometimes telephone, clinic consults, etc. And there you had to kind of rely on changes in the patient's voice, or kind of, just to kind of guide the way you asked questions. The reality is that, say, when I enter a clinic room, so my patient is sitting there, when I enter a clinic room, uh, you get a certain vibe. The patient is anxious, the patient is calm, angry, this, that, so when you see that sort of body language, that may change the way in which you ask questions. And then the way you ask questions will actually change the way they answer, like that change the data that you actually get, right? Now, AI may be able to in the future kind of help you capture those data. At least for now, we don't have that. But you're absolutely right that there are many, say, pieces of data that will be missing from, say, large registry data sets. So that data is only as good as the data that we capture, and it's going to be consisting of laboratory variables, demographic, and clinical characteristics. So, some of these more qualitative things, or even say the way you collect data, is certainly subject to the clinical encounter. And that will depend on the way in which you capture that data. And some people may be more effective at capturing that data versus others. So, say a more senior clinician, someone who's more empathic, actually spends the time listening to your patient rather than typing something at the same time, actually looks at them and, gets that information and asks it in an empathic way, will get different responses from someone who asks it in a very cold, a disengaged fashion. Okay, so, and that is going to be a physician to physician difference. So, certainly these things cannot be captured by AI tools at this time, but maybe in the future, if you have, I don't know, like sensors or, say, capturing data during an encounter and that being fed into the data set fed into a dictated note, like say, as Sonal was saying, word to text, maybe that's an opportunity for embellishing data sets in the longer term and training AI models in a way that those things can be captured.
Dr. Shweta,
I I
what's
have
the industry?
something to add, Dr. Ashwin.
Okay. Yeah.
So, yeah, from the AI perspective, there are many more models which have come up. We can integrate behavioral analytics where the models can understand the emotions of a person. Okay, then that also we can convert it and feed those factors into the models. One thing is behavioral analytics, and now recently the new large language models which have come up, they can easily converse with a patient, right? They can understand the emotions and generate information the same way. So we can maybe in the future few years we can try to integrate all these things so that it's not cold data collection but giving emotions and also understanding what patients are saying about. So we can integrate many other models also in it, Dr. Ashwin.
Hmm.
Dr. Sonal, what do you think? Do you think AI can be a sympathetic doctor as well?
I think so. I think that AI probably does a little bit more than we think it does. At this point, we know that there's enough data out there for AI to detect anger, hostility, even hepatic encephalopathy using voice tone, for example. Just for example, there's a lot of information that is given out. We're talking about non-verbal information at this point, and non-verbal
Right.
information that is not part of collected as lab data as well. So clearly, if you theoretically, yes, if you incorporated a bunch of sensors which are reading people's sort of skin temperature, their heart rate, their breathing pattern, the way they're talking, you could certainly get an understanding their emotional state with the AI that we have currently. It's already being used in certain contexts, perhaps not so much in clinical medicine, but in terms of interpreting emotional state. Now, it all comes down to ultimately data. How much has a model been trained? Has the model known? We are basically pattern recognition machines, aren't we? We also have learned certain ways from our books and from our teachers, and have adopted it as we go forward. I think that now, if you had an AI model that was able to incorporate the wisdom of all, wisdom as in not just the technical wisdom, but the empathy of all the doctors gone by, the teachers gone by, then that would be pretty formidable, wouldn't it?
Absolutely, absolutely. I agree with you. We have a few questions in the chat window, and they've started piling up. So I'll sort of chip away at one or two as we go along. Dr. Shivani asks us if we've actually started. I think Dr. Bhat can answer that better. Have you started using AI tools in patient counseling when speaking about outcomes and prognosis, as in like? Have you shown them like, the AI says this, and I also feel that this is likely to be outcome. You're going to be dead in 6 months, so no point in doing a liver transplant. Is that how you would deal and use AI, for example?
Yeah, so the one tool that we published in Lancet Digital Health that is now in deployment, we are still we are actually deploying that tool. We started deploying, but we have not say used it as yet as a way to communicate risk to patients. So we are planning a prospective clinical trial to enable such discussion. For the time being, it's really being used as a quality of care tool and as a co-pilot. So to be honest, we've not yet done that. Now, I do have a patient partner who is involved in these projects, who offers us guidance as to, what might be the most appropriate way, empathic way to convey risk. So we are involving her in the development of a dashboard that would permit discussion with patients. But I think that's something that has to be done very thoughtfully and carefully, depending on the outcome of interest, because you don't want, say, you don't know 100% if the AI tool will give you an accurate prediction and then unnecessarily worry someone or make them, act on it in a certain way. So I think we really, depending on the tool, we need further research to enable such discussion.
Actually, that leads us on to her next question, Dr. Shivani's, who says, is there an external way to validate or check, or actually say, like an FDA approval of some sort, to say that this AI tool is indeed good, and you actually get a green signal to sort of apply it in standard practice?
So, say for the FDA approved imaging tools that have been approved, those have been the subject of studies, including prospective studies, and then received FDA approval. So, um, I think that's what's required. For example, there have been tools in the past that were deployed without full, research or full assessment of their impact, potential impact, and we're not giving proper predictions. And so, and that may have affected patient care. So, one has to be very, very cautious when dealing with more clinical and laboratory data. I think imaging data is much easier and amenable to predictions. Whereas clinical and laboratory data, you have to be sure that the AI tool will give you predictions that are much better than that of a clinician.
So it's not ready for prime time yet.
I'm saying. Sorry?
I said it's not ready for prime time yet, basically.
No, I mean, sorry. So there are certain tools that are out there now. So, say prediction of deterioration. So, say a patient is on the internal medicine ward and they have changes, subtle changes in their physiological parameters. So there are AI tools out there that can generate a prediction that this patient is likely to go to the intensive care unit in the next day. And so we need to act upon this. There are tools out there, but they're, say, like at St. Michael's Hospital here, they're using such a tool. It's called ChartWatch, but it works in their setting. So then the question is, how do you ensure that such a tool actually works in your setting? You would have to assess whether it's capable of performing in a similarly accurate way. The tool that I was alluding to earlier, say Epic, had a sepsis prediction tool. And I think there were some issues in the way it was predicting. So, some tools are ready for prime time, other tools may not be ready for prime time, but prime time where? Prime time maybe in one specific environment. And then you have to actually assess whether it's generalizable. I think with imaging data, it's much easier. Like radiologic or pathologic data, it's much easier to generate a tool that is generalizable. Whereas with clinical and laboratory data, demographic data, those are going to be subject to environmental factors that will vary from one institution to the other. I mean, I'd welcome Shweta's thoughts on this, but this is my own sense. Like these tools that incorporate clinical and laboratory characteristics or variables are still not fully ready for prime time. They may be ready for prime time in one particular setting, but not like, say, generalizable across many centers. As far as I know, there aren't, tools like this that are so well generalizable across centers.
Yeah, Dr. Mamta, there are no such tools which can be generalized for the whole of the geography. But some tools have been developed which can be used for a particular geographical location. But again, these can't be completely independent. Like these tools can be used by doctors. Okay, they should be used alongside doctors, and those are the people who are taking the final decisions. These tools are just helping doctors make their decisions, right? So generalizing a tool for the whole of the location requires a huge data set,
Mm-hmm.
but that alters the accuracy, so that becomes difficult. Yeah, as per my knowledge, there is no particular tool which is that generalized for now.
Dr. Sonal, what do you think? Like what Dr. Shivani says, you could have 20 different corporate hospitals with 20 different AI models, and how are you going to sort of intervalidate them?
So, I mean, I think a period of confusion is inevitable, as is true with basically most technology. Having a central body like an FDA or a CDESCO or a CE produce some degree of standardization is quite important.
Mm-hmm.
As to because otherwise there is no measure of quality. And I think there was a question regarding the black box as well, and FDA does have certain rules on that as well about how data flow has to be sort of explained when it comes to decision making. What how do sort of so that everybody can understand how the models actually made data, made its inference as such. I think that on the first, what I see this developing it as is that you probably will have a number of models which will then sort of come down to one or two models that are standardized models which are co-pilot kind of models. But eventually, I feel that there will be a period where perhaps insurance decisions will be linked to the fact whether an AI recommendation was followed out or not. For example, if you felt something and the AI model suggested otherwise, there may be a question or challenge if from the payer about why a particular decision was made. So I feel that there will be a period of adjustment and conflict and probably justification. But again, those are reasons for more communication and not less, because I think that eventually we do have to play through this in a certain way. And we are certainly figuring a few things out as they are happening because these are all new questions. It's not like we will be able to use all the old answers that we have.
Mm-hmm.
I think that's a very fair point. There is an inevitable period of sort of turmoil in between before we have some clarity. Dr. Jayanti asked something which actually was running in my mind as well, with regards to the ethical, issues, especially with regards to privacy and data security regulation. Now this is, you know it is patient data which is confidential and which is very private. Now, how confident can hospitals or doctors be with regards to sharing it? Say, for example, I want to work with Toronto and then I want to share it. Um, if if so, then what are the safeguards in this regard? And what are the issues and what are the safeguards? Mamta?
Okay, so are you referring to data sharing specifically or the models, like say the AI models specifically? That's what I'm not sure about here.
Um, well, and she's basically asked about AI, but I'm thinking more with regards to the raw data itself, actually, to start off, and then of course we can speak about the.
Oh, okay. I mean, for raw data itself, then I think any regulations around data transfer hold. So, obtaining ethics approvals and, memoranda of understanding between institutions, etc. But I think, what people are certainly doing these days is transferring the model itself rather than data. So, say I develop a model here in Toronto, and I'd like to validate that data in, a different data set somewhere else at a different institution, whether it's in India or the USA or something. So then I can establish a memorandum with that institution to just transfer the model itself. Now, if it's a published model, it's a bit of a moot point because we have that model already, the code on GitHub, so that could, easily be tested in a different institution. The other thing to keep in mind is that these models can be, say, trained over time further, so fine tuned over time. So it's not like a model, say, published in 2021, needs to remain the same. It should learn over time. And maybe even you can add variables that are interesting to the local context. So, as you mentioned, for example, living donor liver transplantation is added as a variable in an algorithm that was trained in the deceased donor population. Maybe you want to train it further to predict a post-transplant outcome. So you might add that variable. Or, for example, if you're treating patients with GLP-1 receptor agonists, then that variable is added to the model to further improve its performance over time. So there are different variables that you could add on to the model over time. So I think more and more, going back to the primary question, I think more and more people are looking at transferring models as opposed to the actual data. Um, yeah.
Yeah.
I hope that addresses
I
the
mean,
question. And that kind of does away with concerns around privacy and data security.
so
Absolutely.
just to sort of add to that, because we're currently doing a project using AI for frailty, we're using an AI model for frailty. And how that's worked is that they've given us the model and we put it on a dummy server. And all the data that we use in the model is anonymized actually. So there are tools that you could do to sort of over and above your standard HIPAA, protections that to make sure that data privacy is, so these are, but again, like these are works in progress. We do need to, solve these problems as they sort of as we face them. But that's the solution we've come out with, in our institution.
Hmm.
Dr. Shweta?
Yes, Dr. Ashwin. So yeah, I think when we are building models as tech people, we have to be seeing about the privacy issues of the patients. So we have to develop models which don't, uh, put the data out front, like, so that data should not be exposed. So we should inform the tech people that this has to be protected, the data privacy, and even the patient details need to be protected. So that is how we can make sure that we are using models which don't leak our data. So that is one thing. And after deploying the models, once it is on the server, then that won't be an issue because we are just predicting over there. So once it is on the server, it won't be a problem. But while developing, when we are training the model with a huge data set, that is when leakage can occur, and that has to be having some of the security concerns. So people have to, sign some NDAs so that they don't, reveal this information to anybody else. So that risk is there, but we can curb that by necessary precautions we take. So that is my take on this. And coming to the black box techniques and interpretability, yeah, so the black box techniques have an interpretability issue because they are just classifying or giving the answer, but we don't know how they have come up to that answer. So, uh, black box techniques are being extensively used in healthcare and in AI, but how they arrive at a solution is not known. Interpretability would be an issue, but when it is given, when the prediction is given to doctors, they will be able to better analyze and communicate that to patients. So that is one way where we can avoid interpretability issue. Yeah. So those are
Um,
the questions I have answered. Yeah.
Yeah. That actually takes me on to something more general. When anything new is introduced, we always speak about how exciting, how good, how great, how world changing it is. I mean, what are the negatives of actually having AI in our world? I'm sure we need to address that bit, at least superficially. Dr. Bhatt, and then Sonal and Shweta, can you take this in turns? What's bad of AI, or what are the likely negative repercussions of us having incorporated AI in our world?
Yeah. So I think there are a few different potential negative aspects. One of them is, say, if there's already bias in a data set, then you may perpetuate that bias with your AI algorithm. There is potential that, say, physicians take the output of an AI tool as being gospel and just use that and kind of lose some of that clinical intuition over time. So I think, especially in the early days, it's important to maintain some skepticism of an AI tool's prediction, especially if it widely diverges from what, say, particularly an experienced clinician would say is the right approach. So I think it's very important ultimately to ensure that you're helping to build trust among the healthcare community by safe deployment of these tools. Other negative aspects, I think, it's also possible to have too much information, maybe. So, like, say, for example, every time there's a small physiological change in a patient, which may not be clinically meaningful, and you're alerted to these changes, I mean, you can have an kind of overburdened physician who is receiving too much data, too much information that may not be clinically meaningful. So if we're talking about, for example, remote technology, I've seen this in a tool by a colleague who is doing some remote monitoring of patients. There may be many alerts that come up that are not necessarily clinically meaningful. So this is still early days, but I think, again, it involves training the model to understand what is clinically meaningful versus what is not. Those are the main, negatives I can think of. The other thing is actually it's computationally expensive to develop these models, and at least in early days to even deploy these models to ensure that they're doing good for your patients as opposed to any negative repercussions. You do need people who are going to be monitoring those outputs and making sure that safe infrastructure, safe data engineering infrastructure is in place. So all of this does require resources, and so it is a bit of a negative for AI tool deployment at this point. That it is going to require some financial resource investment to deploy these tools, at least in early days. But I think in the longer term, there's the potential to regain any such resources that have been lost through decreased healthcare costs.
Dr. Sonal, what about you? What do you feel is bad about
Yeah,
AI?
I think bias certainly worries me because we all as humans have our own biases, and we know that institutions have biases traditionally, against say disadvantaged populations, against women, against minorities, for example. These come out in the data whenever we look at large data sets, like even what Dr. Bhatt has presented. So AI is certainly going to amplify those differences, if not sort of mindfully used over the short term, and that's
Mm-hmm.
because it's learning from the data that's been presented to itself. Again, it goes down to pattern recognition, as in, say, in law enforcement. If you're a certain color, for example, they might feel that you're more likely to be a criminal, for example. And so I think that these are patterns that are inbuilt into us as human beings, but it probably becomes a bigger problem if it becomes an institutional, um, you know, sort of stance that AI might make it. So that certainly is a big worry. The resources part cannot be understated because we're still talking about relatively modest amounts, but when the amount of resources that it takes to train something like a GI model are humongous actually, and over 2030, it's likely to take up some. I mean, I was reading somewhere that between 1 to 33% of the power generated. I mean, that's quite a lot of sort of investment of resources in training a model. Now, whether it's cost beneficial or not is difficult to say because at this point it's too early in the technology to sort of understand what kind of benefits it will bring. But it is certainly exciting, it's transformative, and I mean, the future is here. We can go into it either kicking or screaming or, or see how best to adapt it to our practice.
Uh, that's a very optimistic answer. I would like to actually go with that answer. Dr. Shweta, what about you? From the other side, what are your thoughts about what's all negative about this thing?
Yes, Dr. Ashwin. So, as a data scientist, I can think of few things. These are not like exactly negatives, but some drawbacks which we can address. Yeah. So, some part of it we have already discussed during this session. So, one would be the data security issue, which will always be a matter of concern for us. Another one is generalizability. Okay, building a model here and using it somewhere else would become a difficult thing. But if you want to train the model for the whole data set, again, that needs huge resources. So computationally, it becomes very difficult. The third point I want to bring it in front is the error. Okay, if there is even 1% error in a model, we can't take that chance, especially in healthcare. In any other sector, it would not have such impact. But in healthcare, 1% error or one patient being misclassified would create a lot of problems. So, this drawback we can try to manage, or we can try to increase the accuracies of the AI models by training them with lots of data. Huge data sets would help us do this thing.
Mhm.
Yes. So, another thing would be about labeling the data. Mainly when it comes to image data, we have to have doctor's inputs, right? If we want to train a model, we for sure need a doctor's input on where the particular cancer is or where the exact location is. So,
Mhm.
and that brings already doctors are burdened with a lot of work, and we needing a lot of inputs from the doctors, creates a bit of difficult schedule. Like we need constant annotations and to train the model. If we don't have the proper annotations, then the model won't work well. So there is interdependency between these disciplines. So that is one more issue we have to address. This is not the case with other sectors wherein we just can get the domain knowledge and do it. But here we especially need doctors' inputs to get a good model at the end of the day. So those are my takes as a data scientist on integrating AI in healthcare. That being said, if in another few years, but the working well with these interdisciplinary sectors, we can create wonders, right? Such models can help patients in a very huge way if we are able to do these things in the near future.
Perfect. Now, actually, I was asking something more existential, and I think we should wrap up with that. We've been at it for the last 2 hours. So what I was wondering was more like a Terminator or a Star Trek kind of a scenario where doctors are completely replaced by AI. Now, I do understand it is very futuristic, but do you guys see that happening? Because that's also one of the questions which's been asked in our chat window.
Can I ask you that same question? I mean, to actually to who has asked the question as well. What do you think that we bring to patients as doctors? Are we just analytical machines? Are we people who interpret results for them? Are we people who take out their gallbladders? Are we people who give them medicines? Or are we more than the sum of our parts? So I think that that's probably a more fundamental question for ourselves to reflect on.
Mhm.
What are we adding to the knowledge that we are bringing to our patients? The knowledge is accessible, right? Knowledge is democratic now. So you give an LFT, especially in Bangalore, your patient would have Googled the LFT and they would have come out with an interpretation and spoken to a number of people. So what are we adding to the patient experience and to the patient's sort of quality of life by doing what we do? So I think the argument is that AI might help us to do more of what makes us human and less of perhaps take away a lot of the burden of analysis that actually currently takes up all our life. So, like for example, the time that you spend in a patient, the UK, the data is that the amount of eye contact is only 30 seconds, right, in a patient contact. The rest of the time is on the computer. So, if there is a mechanism by which we can change that, we can reclaim that space, then perhaps we add more value, no? Because
Yes.
if we don't add value, we go, no?
Sure, fair enough. Fair. Uh, Dr. Bhatt, your last thoughts about this, and what's your take on what Dr. Swamal just said?
Yeah, I don't think that that's likely to happen. I mean, if that happens, again, AI in healthcare is the last, space where AI has not permeated. If you're looking at a Terminator-like scenario, I think that's more likely to happen in the other spaces where it's already part and parcel of practice, like say in business and other areas. But I would say in general, as physicians, or as physicians who hold different hats, like say, you do a lot of delegating. So there's a lot of delegating that happens, say, as we manage our clinical programs, our research programs, our personal lives. Say if you have children, then you have someone who helps you with that aspect. Looking after your children when you can't. Cooking, cleaning, all of these things. There's a lot of delegation that happens because the reality is that we only have 24 hours in the day. We need a certain amount of sleep and so on. So um, I would say, look at AI as a co-pilot, as a potential for positive delegation of tasks, as Dr. Asthana was mentioning, rather than as, a competitor or someone wanting to take over your practice. Because I think in the end, you want to do the best possible for your patient. And if that best possible means including AI in helping you take care of your patient optimally, then we should be very open to doing that. And ultimately, if it helps our healthcare system and decreases costs as well, it's a win-win for everyone. So I think we should look at it as a positive, in a positive light, rather than looking at it as something that will, completely derail our clinical practice.
Thank you for that. Dr. Shweta, any last words, and what's your thought about what we speak?
Yes, Dr. Ashwin. So, replacing doctors with AI is not, we are going to see in the near future at least, right? We are just trying to, help or ease out doctors' workload by creating models which will help them make better predictions or take decisions. So, we as data scientists are just trying to, develop models to help doctors. So, we are not trying to replace them. So, that is my take. And integrating AI in healthcare would give great benefits to everyone, to the doctors, to patients, and to everyone over there. So we can create new models which will improve patient care and also decrease the costs which will be, you know, which the patients are burdened on. So that is my take, Dr. Ashwin.
Perfect. I think it can't be encapsulated better. Um, Thank you to all the panelists. We've been on for the last 2 hours. Thank you, Dr. Bhatt, for that excellent lecture to start off and to lay the foundation for this panel discussion.
Pleasure.
And it has been very educational for me. I'm sure it's been so for all those who have attended this session. Thank you so much. And I think we'll close it here and hopefully meet in another forum.
Okay.
Thank you
Thank you
so
so
much,
much.
Dr. Ashwin.
Okay. Thanks so much, everyone. It was wonderful speaking with you. Have a nice evening.
Thank you, Dr. Mamta. Thank you, everyone.